Healthbeat and Facebook Live. Now, normally I record Healthbeat, which is my digital program that posts every Monday and Thursday at WNYT.com. I call it Your Health Info on the Go, and clearly we need that now because so much is going on so quickly. Back on March 11th, 6 weeks ago, I hosted a Facebook Live with our guest today, Dr. Arthur Grant. He's an infectious disease specialist from St. Peter's Health Partners. And hi, Dr. Grant. Thanks for joining us.
Hi, how are you?
Good. Now, back on March 11th, you and I were sitting across from each other, but the world has changed so much in 6 weeks, and so have the concerns that people have as well. And now, of course, we're all quarantining, isolating, social distancing, and we're not allowing anybody in the station. I put out a request for questions yesterday, and we're going to get to the ones that you're going to send in today. Debbie asked, is there research showing that people who've had the pneumonia vaccine have milder symptoms if they contract COVID-19?
Now, my understanding is the vaccine for bacterial pneumonia or streptococcal pneumonia does not affect your susceptibility to novel coronavirus. That's my understanding at this time.
Right, so separate and apart. There's also a lot of concern, questions about wearing masks, Dr. Grant, and Jimmy sort of wants a protocol about it. You know, the N95, the cloth ones, how to wear them, when to wear them, and what to do with them.
So the way that the recommendations are right now is that along with social distancing, people consider the use of wearing a mask when in public. And that's not going to be probably a surgical or medical grade mask. That's going to be some sort of a face cover, usually a homemade device out of cloth or clothing material that you put on your face, you attach behind your ears, and you use it to prevent droplet spread when in a public place. And I believe the CDC has some recommendations on how to make these things and what materials are reasonable. This is not a medical grade mask. The point of using one of these is to decrease droplet transmission from yourself, and hopefully if everybody wears them, from other people to you, which could potentially slow the transmission of the disease in public spaces. The best way to slow the transmission in public space is not to be in a public space, but of course people go out and do things like shop for groceries. So in situations like that, you would want to put on one of these devices to kind of protect yourself and others.
There's some question. Once I wear it, so I tie the bandana or the mask that I have, and I've worn it out. Maybe I've worn it for 10 minutes, maybe I've worn it for a half hour. You just don't touch the front, right? Because that's where the germs would be residing. Take it off by the earpieces. But what do I do with it next? Can I re-wear it?
I'm sorry, I'm losing you on the audio for a second. What was the question? Was whether you could wear a mask?
Right. Can I use it again? I've worn it out. Can I wear it again?
You're talking about a cloth mask?
Cloth mask. Do I have to wash it immediately? What do I do with it?
Yeah. Throw it in the washing machine, wash it with soap and water, and then you can reuse it.
Okay, so I shouldn't put it in the back seat of the car and put it on tomorrow?
Probably not the best way to handle it. If you're in a public place where you think you might have been around somebody who could potentially have spread it to you, then the best thing to do is when you get home, just wash it.
Yeah, and because that's still a big confusion. And then people are not wearing these masks appropriately, are they?
Well, this is really, this is not a medical grade mask. We're telling people to make a mask at home using cloth and rubber bands and put it on. What is appropriate in that situation? How are these things supposed to do to work? We don't know. We're not regulating them. We're not telling people exactly what material to use. Really, the strategy is to do the best you can.
And let me jump in. Also, you've got to cover your nose and your mouth. Wearing it under your chin is not going to protect you.
I'm sorry, the mask is going to cover your nose and it's going to cover your mouth. That's the idea. It's not going to make a perfect seal. It's going to prevent droplets from you. It's going to prevent droplets from others getting to you. That's the
I know we've got a little delay here. The point being, cover your nose, cover your mouth. I've seen people wear it below their nose, and that's not really doing anybody any good, is it?
If you're just covering your mouth and not your nose, no, it's probably not going to be all that effective. Again, we're trying to do something. We're not trying to do
Yeah.
everything with these. Masks.
Helene writes that she's heard about different amount of time after you've had COVID-19 to be considered recovered. Is it no fever and symptoms, 72 hours or 14 days? What's the time frame?
Well, unfortunately, we've seen colonization of this virus beyond the period of convalescence, beyond the period of recovery. We're still recommending 14 days as far as trying to reintegrate yourself with family and people that you're going to be close with. But we're still at the point where nobody really knows how long you are infective, meaning how long you're colonized with this virus. And the only way we're going to really get a good handle on that is increased testing.
Mm-hmm. And we're going to get to that in a couple of minutes. Teresa wants to know, what's the latest on folks who have recovered? Is there immunity, and if so, for how long?
Is there what?
Immunity once you recover.
Immunity.
And for how long?
Most people that recover from viral infections do develop antibodies, do develop immunity. We're still too early in this epidemic to really know what the long-term population is going to look like after this does die down, and how many people are going to be immune and how long their immunity is going to last. It's a little too early to say. Yeah, because there's also that question, and we're seeing this come out of some of the Asian countries, that it appears that perhaps some people have become infected again, or maybe they just didn't clear it the first time. Do we have any more clarity on that issue? There have been reports of people with recurrent symptoms and possible recurrent infections. It's really hard to say because the colonization can last a while, and it's not necessarily a reinfection. But there have been people that have been sick with this for more than a few weeks, and it's an evolving situation. Is there an indication as to when Albany, the capital region, will hit the peak, and we can start to get life a little back to normal? Well, I think the state statistics have been reported by the governor, and I think that the amount of deaths has decreased a little bit over the last couple of days. I think we dropped below 500 deaths a day. I'm not really the numbers person, but I seem to recall reading that. Are we at the peak yet? Probably, but it remains to be seen as far as what's going to happen when people start easing up on the social distancing, whether we're going to have additional cases or whether it's going to continue to drop. It's interesting report out today that I'm sure you saw, that it appears that the first death was much earlier than we thought. It would have been back in January from COVID-19, and a couple of viewers were, they had a crazy flu back in January, and of course now they want to know if in fact it was COVID-19 and not the flu. What does this mean for us as a community? And Toto, that the first case was probably a lot earlier than anybody thought. As far as the first cases in the Capital District?
No, in the country. In the country? Yeah.
It's likely that there was a case in the country that happened before we tested the person, but we can't isolate a specific individual case that brought this virus into the United States, and we believe it came from multiple places. The New York and the California strain are slightly different and suggest different origins from different places where people were traveling.
Mm-hmm. And there are some slight shifts in the virus. How does that affect how we will treat it and how we will have a vaccine for it?
Coronavirus is an RNA virus, and it's not surprising that there is, over time, some genetic shifts, and those changes may be different in different places, and it will lead to strains of the virus that are slightly different. The clinical implications of this, I don't think it really matters that much as far as the illness that it causes, as far as the the treatment options that we're giving people. But it may have implications in the future because, if the virus could potentially have additional shifting, and that's what RNA viruses can do.
There's also a question someone had about when we're testing for the antibodies, that are these antibodies specific to this coronavirus? Would it not show up if you'd had any other coronavirus? Because we know that many colds are triggered by a coronavirus.
Yeah, there are other diseases that are caused by coronaviruses, and of course SARS and MERS, which we've seen before. For an antibody test to be a useful test, it's going to have to be specific to this particular virus. It's not very useful if it picks up all coronaviruses. There's no commercially available antibody test at this time, and it's still only being done in research settings, so it's hard to say what the antibody test is going to be like when we don't have one yet.
I'm going through some of the questions. Lynn wants to know, they've got an N95 mask. Can it be re-worn if there is a week in between having worn it? So say they went to the grocery store last Thursday, can they wear it again tomorrow out to the grocery store? Is it still effective? Are they okay with that?
They should be using an N95 mask to go to the grocery store.
That may be what they've got, though, so they are.
Yeah, I mean, if they happen to have an N95 mask that they're using at the grocery store, again, when you contaminate a mask, you potentially could carry particles of virus on it. But in reality, that's not really the way this virus is being spread. This virus is still mostly being spread person to person, droplet and airborne transmission from sick person to well person. Even though the virus can live on surfaces for long periods of time, as we've seen, that's not the mode of transmission, and that's not the biggest worry.
Viewer Bob writes, he wonders if this is ever going to go away. Will we ever be safe again?
No, the epidemic is going to cool off. It's not going to last forever, but the virus itself may stick around for a while and may become an issue that we see over a period of years. We won't see the volume of sick people in the hospital like we did with this outbreak in March and April, but we'll certainly see cases of it for months to come.
And that also raises the whole issue about herd immunity, Dr. Gran. For those who may not be familiar with that term, that's when enough of us have been exposed, we have immunity so that it doesn't run as rampant through a community. This was a new novel virus, and we hadn't been exposed, and woof, took off like, a match on dry wood. But as we all stay home, it's been theorized that as we social distance to tamp this down, then that also slows down herd immunity. Can you talk a little bit about sort of the double-edged sword here?
I don't see it as a double-edged sword. Herd immunity is a good thing. There's a reason why we vaccinate large numbers of people, even though the sickest people can't take a live vaccine, for example, against measles or chickenpox. We vaccinate everybody so that they don't have the virus, so they don't give it to the sick person. Having a degree of herd immunity is protective to the people that do not make immunity, do not make antibodies, or have such poor immune systems that they lose their immunity, or they are highly susceptible to getting very sick with this or some other sort of infection. So herd immunity I don't see as a double-edged sword. I think it's a very good thing.
I meant in the sense that, you see, when we're not sitting face-to-face, it gets a little tough. If we're all home and we're not being exposed, so that slows how many of us, in fact, have been exposed and may have built up antibodies.
That's the idea. If you have been exposed, you have produced antibodies, and hopefully you will not get this infection again. That's how the immune system works.
We've got Brian wants to know, why do we test for fevers when people may in fact be shedding virus before they're symptomatic?
There is, that's one of the problems with this virus, and one of the reasons it's been so highly contagious and widespread is that it's not just people that are highly symptomatic that have evidence of virus in their nose and on testing. People with limited symptoms, people who are even asymptomatic, or people who have convalesced and recovered from their infection are still testing positive by PCR, which means they still have particles of virus in their nose and potentially could still be contagious. And that's why we've made increased testing such a focus of our strategy to reintegrate social closeness, because you really have to know who's still colonized, even if they were not that sick, even if they are not that symptomatic, because we want to try to stop this thing from continuing to spread.
Yeah, and that becomes the problem, testing. How much, where are we testing? I think there's also been some confusion over why the Department of Health is testing to see if you've got the antibodies, but doing it so randomly. I know a lot of people who think they had this disease want to be tested, but that's not who the Department of Health was looking for in this go-round, because they need the randomness of it. Can you explain that a little bit?
Well, the focus right now is not on testing everybody to see if they've been exposed. People are interested in that from a standpoint of their own immunity, but I'm actually not sure what the Department of Health is doing as far as antibody testing. My understanding is that antibody testing is still an experimental test that is not commercially available, is not widespread. So the point of doing testing by the health department, if that's what they're really doing, is to determine levels of positivity in the community for a comparative nationwide and local assessments. It's not to tell people that they're immune to it and don't have the virus anymore. You have to consider the limitations of antibody testing in all situations when we're looking for evidence of effectiveness.
Yeah, and I know a lot of folks want to be tested, and Albany Med does a daily YouTube info session, and their doctors yesterday spoke that they anticipate next week that there will be an antibody test that will be more widely available, that they've developed. They're waiting for final approval, and I'm sure St. Peter's Health Partners will be involved in that as well. I had an interesting question from Sylvia, wanting to know if there's a mandatory 14-day quarantine on inbound planes landing here in Albany. I'm not aware of that. Are you?
I'm not aware of any mandatory quarantine from planes. I mean, Albany is an international airport, and that I guess planes go to Canada, but it's not exactly people traveling along all around the world. I'm not sure of any required quarantines from domestic travelers coming from other parts of the country to the Capital District. Again, I'm not really that much of an expert on the policy part of it.
What are we still not doing, I don't want to say right, but best to improve our chances of staying healthy? Is it still the people who are smoking, not taking medications? A study out today indicates that if you have an airway disorder like asthma, you're at greater risk, one, of contracting COVID-19, and two, of having serious complications. Let's talk a little bit about that and how to stay well.
There are some things you can change and some things that you can change. We've seen on multiple studies that there are certain underlying health conditions that put you at a higher risk for developing serious infection with this virus. Among those, high blood pressure, diabetes, heart disease, and chronic lung disease. Those are the things you really, if you have those conditions, there's not that much you can do about them to change your conditions other than to practice your social distancing and staying away from sick people. The things that you can control, diet, exercise, smoking, alcohol consumption, those are the big things that I think we should look at. Healthy diet is very important. Drinking lots of fluid is very important. Smoking cessation, if you can do that, that's very important. Avoiding alcohol, certainly excessive alcohol consumption is important. And getting a good night's sleep. You can't underestimate the importance of that.
Yeah, because that helps with our immune systems as well. Just trying to keep tabs on the questions that are coming in. What is it about obesity that raises your risk for contracting this disease and then having a bad outcome? Is it inflammation? Is that part of it?
Well, I would take a step back. I'm not sure that obesity is a risk factor for contracting the virus, but certainly is a risk factor as an underlying condition for having a more severe case of COVID. In general, obesity and the metabolic syndrome changes the way in which your immune system works. I'm not going to get into the specifics of that, but it does make you more susceptible to having serious infections and more susceptible to having serious problems from non-infectious diseases as well.
Mm-hmm. And, you know, the big question everybody wants to know is, when are we going to be able to start to reintegrate into our old lives? What are you looking for? What hallmarks do you need to see that say, okay, it's starting to look more likely that we can do this?
I'm sorry, could you just repeat the question? I had
Sure. Technology. Most folks want to know, you know, when we're going to be able to resume our old lives. So what is it that you as an infectious disease specialist are looking for? What hallmarks do you want to see to feel more comfortable that we can, in fact, begin to, you know, open things up?
What am I looking for from the population to say that we can start getting back to normal lives? Is that what you're asking?
Pretty much, yes.
So what I want to see is, number one, a decrease in cases, and you know, I think that we're on the way to that. Number two, an increase in testing so that we have an idea of who's contagious and who isn't. And number three, a relaxation on the burdens to the healthcare system, because a lot of the problems with this virus is that it came so quickly, it completely overwhelmed the healthcare system, especially in populous places like New York City, and made it impossible for doctors to take care of people and even find room for them inside the hospitals. So need to decrease the burden on the health system so that when there inevitably are additional cases, when social distancing limits are eased, we have the capacity to take care of these people.
Yeah. There is something really kind of wonky that goes on with COVID-19, that people have very low oxygen levels, but they're functioning in a way that medicine wouldn't expect them to be able to function. And something called surfactant that covers our lungs is being implicated in this. Can you give us a better understanding of what's going on in the lungs of patients? There's so many questions about this.
There's a lot of technical stuff as far as how the virus affects the type 2 pneumocytes, the cells inside the lung, how the virus attaches to the angiotensin converting receptor, and how it affects surfactant, how it affects other chemical pathways. Essentially, what this does is it damages cells inside the lungs and causes lung damage, but it has other effects on the body as well. And a lot of the severe illness is related to some of the other effects, not just on the lung cells, but effects on the blood and other systems in the body. So I'm not sure that understanding the physiology of exactly how the virus works on the lung cell, which honestly I still don't exactly know how it does, work on the pneumocytes. I don't think anybody does. It's a complex process, but it also involves other systems in the body. So the technical stuff is a little bit, it's a little bit peripheral to understanding the viral effects on people and what you can do about things.
Yeah, and then we've got another question. Let me just quick get to it. You and so many others in the infectious disease community, virology, are pushing for greater testing. There's a lot of frustration in the public, and I know it's starting to ease, the testing, but unless you have really serious symptoms, you can't even get the script to go and get the test. So how do we really know how many people have been infected, and how widespread this is?
Well, you can't know for sure. We know that many people who have this infection are minimally symptomatic or have low levels of symptomatology or just don't want to see a doctor, and so we don't know if they're positive. And some people who do have low levels of symptoms are not being recommended to go to get tested because it's not really going to affect what we do, unless of course their symptoms get worse. Until we have the availability of widespread testing, we just can't do it. We can't have everybody come down to the hospital or the clinic or the doctor's office and get tested. There has to be widespread availability. There has to be millions of testing kits, and until we really have that number, we can't do that kind of testing.
And then we don't really have a very as accurate a picture of the spread in the community. And at this point, what's the latest thinking on why some people are felled by this and others who ostensibly seem to have the same risk factors skate through? Maybe you don't even know that they had it. Is it a change in the virus, or is it something genetic in our systems?
I'm sure there's a bit of both. Some people are probably genetically more susceptible to this, but I'm unconvinced that that's the reason for widespread illness. I don't think that it's a genetic thing, because we see so many cases in, say, Queens County, which is the most culturally diverse place probably in the United States, maybe even the world. And there are so many cases there that it doesn't really fit with a genetic predisposition for illness. So it's still mostly transmission and proximity that is causing widespread disease in certain pockets of the country, in major cities. Why do certain people get sicker than other people? That's a fundamental question of infectious diseases, immunology, and medicine in general. Why do some people get really sick with the flu? Why do some people get really sick with pneumonia or a urinary tract infection? All of these things are, there's technical answers, and you can go into the genetics of certain people, but in reality, there's still a bit of doubt about why people get extremely sick with certain things.
Yeah. So we touched on, I'm taking a look at the questions as we're losing time. Eventually, will everybody be able to get an antibody testing? I think that's probably unknown at this point, because we've been promised widespread testing to see if you're sick, and that hasn't materialized at this point.
So hopefully soon.
I'm sorry?
No, I said hopefully soon.
Hopefully soon. And should we all just assume that everybody is infected when we go out?
Well, I mean, you don't necessarily assume everyone is infected, but you have to assume that you are potentially at risk when you're in a public place with a lot of people, which is why we're still recommending social distancing. We're still recommending things like masks when you go to grocery stores and in public.
So let's be good citizens to each other, wear the mask, wash your hands, don't linger in the supermarket, and I think the other recommendation is just go in, get your goods, and come home. Don't bring the family shopping, and keep that social distancing for the time being. Would that be your prescription?
I think so. I mean, I'm hoping to have, more optimistic and recommendations in the near future, but for now, I think that we still have to continue to do this.
And before I let you go, hydroxychloroquine is not appearing to be the miracle drug that some had hoped that it was going to be. In fact, there are increasing numbers of reports of bad outcomes using it, and also effects on the heart. Now we're looking at remdesivir, and that's a little bit more hopeful. What are you seeing coming down the pike? Any in the literature that you're seeing? Is there something else out there that maybe is holding big hope?
Well, I'm hopeful for convalescent plasma. Convalescent plasma means transfusion of the non-blood part of your blood, the non-red blood cell part of your blood, from somebody who survived and got over their illness to somebody who is acutely sick. There's still lack of conclusive data on its benefit, but I'm certainly hopeful that this is going to prove to be something that's useful for people in the future. And I know that the Red Cross is taking blood from people who have previously had infection and cleared infection and are no longer sick. And I believe you have to have been sick more than a month ago in order to be able to donate blood. But if you are somebody who fits into that category and have recovered from your virus, I think you can do a very good thing for your fellow men for the future if you can donate plasma.
And I thank you so very much, Dr. Arthur Grant, infectious disease specialist at St. Peter's Health Partners. Thanks so very much for taking the time, and you know we're going to be in touch as this continues. Take care. Wash your hands, right?
Absolutely. Thanks, Benita.
Thank you, and thank you all for spending some time with us today on this very special Health Beat and our Facebook Live. Take care.